I'm Ilya Sleptsov. I'm endocrine surgeon with 18 years of experience. Let me tell you some words about our new technique. Dear colleagues and patients, today I would like to discuss a new technology we have developed in our clinic this year. We call it tension-free thyroidectomy, or TFT. At first, I would like to tell you some words about our center. Our clinic is located in St. Petersburg. This is the second largest city of Russia. We have 62 beds and a team of 19 endocrine surgeons, 20 endocrinologists, 4 therapeutists, and we service the whole territory of Russia and the most of the surrounding countries. We perform 6,000 endocrine surgeries a year, and every year the number of our surgeries rises. At first, I would like to tell you a bit about the anatomy of the thyroid gland. There are 2 arteries that supply blood to the thyroid, inferior and superior. The superior thyroid artery goes to the upper pole of the thyroid lobe. Inferior thyroid artery goes posteriorly to the thyroid lobe and supplies blood not only to the thyroid, but also to parathyroid glands. Superior thyroid artery supplies about 20% of the whole blood volume. Inferior thyroid artery about 80%. That means inferior thyroid artery is the main source of blood supply of the thyroid. There are 3 main veins that drain the blood from the thyroid: superior, lateral, and inferior ones. They drain the blood into the internal jugular vein. There are 2 main nerves of the larynx, inferior and superior. The inferior laryngeal nerve, or recurrent laryngeal nerve, is very important for endocrine surgeons. The damage of this nerve causes voice loss or respiratory problems for the patient. If the superior laryngeal nerve is damaged, the patient loses the ability to pitch high notes. The technique of conventional thyroidectomy is described in many textbooks. Most of these books describe the technology in the same way. In the first step, the surgeon divides the upper pole vessels. In the second step, the surgeon pulls the thyroid out from the neck. In the third step, he mobilizes the recurrent laryngeal nerve, then separates parathyroid glands from the thyroid, and only then he divides the inferior thyroid artery, the main source of the blood supply. This technique can cause several problems. When the thyroid is pulled out from the neck, it creates tension in the vessels, and vessels can compress the recurrent laryngeal nerve. The recurrent laryngeal nerve, then, can lose its function. Here is a typical picture from a textbook. The thyroid lobe is completely pulled out from the neck. You can find these pictures everywhere. I would like to stress that all the maneuvers of the conventional thyroidectomy are performed from the lateral side of the thyroid. That means that medial and upward traction is applied to the thyroid to get a better view of the recurrent laryngeal nerve and parathyroid glands. There are 5 main disadvantages of the conventional thyroidectomy. Curved access to the main anatomical structures: parathyroid glands, vessels, and recurrent laryngeal nerve. The main blood supply source, the inferior thyroid artery, is blocked at the very last moment of the operation, and the veins are cut at the very first moment of this surgery. Because the thyroid is pulled out from the neck, the recurrent laryngeal nerve is under tension during all the time of surgery. When the surgeon is dividing the upper pole vessels, he can damage the external branch of the superior laryngeal nerve. Parathyroid vessels can be also damaged when the thyroid is pulled out from the neck. Surgeons use several technologies to avoid complications. They try to apply gentle traction to the thyroid. They use neuromonitoring, they use magnifying loops, parathyroid visualization devices like PTI. Sometimes they even use ICG to control parathyroid perfusion. But these are just tools. They don't change the fundamentals of thyroidectomy. We have to change the approach to this surgery to reduce the risk of complications. We performed a single surgeon study, which started in August 2021. Since that time, I started to operate all the thyroid cases with new technique. I used Inamed neuromonitoring, Univet magnifying loops, Dr. Kim light source and camera, Herbivire as electrocoagulation unit, and Ethicon harmonic as harmonic scalpel. I also used 3mm titanium clips. Before and after the surgery, we performed vocal fold assessment by ultrasound or endoscopy. We also measured PTH and ionized calcium levels on the day of surgery, post-op days 1 and 14. For now, 92 patients were operated using new technique. Among them, 35 patients had total thyroidectomy and all the others had lobectomy. Thyroid nodule size ranged from 8 to 95 millimeters. And we had 127 nerves at risk. The first step of the tension-free thyroidectomy is dividing of the thyroid isthmus to get access to the medial surface of the thyroid lobe. The second step of the tension-free thyroidectomy is dissection of the Barry's ligament fibers. The third step of TFT is a lateral traction of the thyroid lobe and division of the final branches of thyroid vessels. This step should end with complete mobilization of the thyroid lobe from the trachea and the main vessels. In the fourth step of TFT, we mobilize the superior parathyroid gland from the thyroid. We do it from the medial surface of the thyroid lobe, protecting anastomosis between the superior and inferior thyroid vessels. In the fifth step of TFT, we mobilize the inferior parathyroid gland, and we do it also from the medial surface of the thyroid. In this stage, we can preserve most of the parathyroid veins. In the sixth step, we pull the thyroid lobe out from the neck, starting from its lower pole. In the last step of the surgery, we pull the thyroid lobe downwards. That increases the space between the superior pole of the lobe and the external branch of the superior laryngeal nerve to protect it from injury. Then we divide the superior pole vessels. Let's focus on the results. We never lost a signal or created a palsy on the recurrent laryngeal nerve. That means 127 nerves were protected with the help of TFT. We had one case of PTH drop on post-op day 1, but in this case, PTH level became normal on post-op day 14. Our results show that lateral traction of the thyroid lobe is safe, and we believe that mobilization of the thyroid from its lateral surface gives the surgeon a better level of precision. These are several specific features of tension-free thyroidectomy. The first, the most nervous part of the surgery, the mobilization of the thyroid lobe from the trachea and the vessels, is performed first. The upper parathyroid gland is always mobilized in the second step of the surgery. The most important maneuvers are performed from the medial surface of the thyroid lobe. The lobe can be taken out from the neck only when recurrent laryngeal nerve and parathyroids are completely mobilized. Neuromonitoring is used only to avoid direct damage of the nerve. I can compare the situation in TFT, the situation of mobilization of recurrent laryngeal nerve with corridor. In corridor, the closer torero is to the bull, the safer he is. And in our surgery, the closer we are to the nerve, the safer the nerve is. Our technique helps to overcome 5 main disadvantages of the conventional thyroidectomy. It provides direct access to the main anatomical structures. The main source of blood supply is blocked at the very beginning of the surgery. Recurrent laryngeal nerve is kept without tension during the whole time of the surgery. External branch of the superior laryngeal nerve is preserved, and parathyroid vessels and anastomosis between the superior and inferior thyroid vessels are protected. Here is my personal opinion. After 7,000 of conventional thyroidectomies and 92 tension-free thyroidectomies, I will never operate the thyroid from the lateral side. You can start doing tension-free thyroidectomy only when you get enough experience with conventional surgery. This is important. Also remember that neuromonitoring and headlamps are very important for tension-free thyroidectomy. Use them. Thank you for your attention. I hope that tension-free thyroidectomy will be used by surgeons all over the world. If you are interested in visiting our clinic and training, please use my contacts. Come to St. Petersburg, be our guest.